Yeah, I've got 3 presentations to do.
Oh,
So,
wow. So I hope you had a better time than Sue and I.
why is that?
Got the 5 o'clock slot.
Yeah, I've got 2 morning slots. So, but I've got the morning of the Thursday after the dinner on the Wednesday night, I guess.
All
So,
right. Okay.
yeah. The graveyard shift. Yeah.
How are you doing, Aileen?
Good, thank you.
You were organizing you organized the roster for the booth. I didn't know that we had that either.
Yes.
So what's there?
So on our booth we had it's just people wanted to come talk to us.
I see.
That are at the conference, but I've just been working on so different teams have sent through some slides as well. So we've got like a rolling presentation.
Right.
Of just information.
I see.
It's just a nice networking event. People to engage. What we're doing.
Yeah, it's a slight different this time, huh? Because everyone is under kind of one umbrella. In the past, used to be, it's literally it will be interesting. It will be interesting.
Yes.
I tried to push my earphone into my ear and it hung up, and then it started playing a YouTube video. I was like, where's that sound come from? It's like, oh, great. Yeah, no, so it is going to be really different, Solly. I think the interesting thing to me is it's almost a Te Whatu Water conference, if you know what I mean, rather than
yes,
anyone else. So
this is an interesting part because you see in other conferences that happen around the world, they always have a theme on the conference. And the theme just drives everything what's going around the topics and the keynotes and so on and so on. So it's and it go that really strong. But again, it becomes that exchanging of information. I think it's in some ways probably would be a good way for people to collaborate and share knowledge if the ones that are actually a privilege enough to attend. I mean, not everyone has probably been kind of like able to attend really.
Yeah, so the NHS has the Confederation Conference, which is probably their kind of, I would think about it as the NHS conference, and it has quite a bit of digital stuff as a part of it.
Yeah.
But then I think they did an NHS digital conference as well, separate to that. So we obviously don't have that. We don't have a Te Whatu Water conference or a Health NZ conference. Maybe I should quit my job and start a business.
Well, there is this the chapter of it's the biggest conference that you got in the States as well. That and I thought, why we don't have a chapter of that in New Zealand, because we could really just piggyback what they're doing there and just get some, have a little chapter here, and we can actually be exposed to the stuff that they're doing because they have much more kind of like reach than we have little New Zealand into speakers and stuff like that. So.
Yeah, well, still good for us to kind of not be doubling up a bunch of stuff, or learn from each other or inspire each other. So.
Yeah, that's right. That's why I'm thinking that have a chapter and having kind of in a similar time zone. So and then you have actually it's only one time in the year that people really kind of go for a conference rather than actually being pinging through 5 times through different places around the world. So it would be interesting.
I was thinking about time zone and I was like, oh, maybe we need to run it between like 8 at night and 8 in the morning.
Well, there is one that happens around the United Nations. It's having actually a talk about the Manhattan Manifesto, which New Zealand was there, and she's going to do a talk in HiNZ, but the manifesto is going to be online at 3 a.m. in New Zealand time, so on the same week as the HiNZ, but is right. Actually, I would say I would try to push myself to be there just to listen, because there are 5 major speakers there that really, when do you have when you have the money to pay to listen to those people, it's free.
Cool. I was going to bring up the program. I've looked at some of it, but I haven't looked at lots. And I was kind of plan was maybe spend a little bit of time talking about, are you talking, Michael, at the conference?
Which conference is this? Sorry, I missed that start of the conversation.
HiNZ conference next week.
No, unfortunately, I can't make it. No, I haven't actually gone to a HiNZ conference, so
Oh wow,
I don't really have much visibility in that area.
yeah.
And I'm definitely keen. I know some of my colleagues are going from Waitaha here. So Rob Halloran, who's the allied health sort of lead in workforce.
Yeah. So it's normally about 2,000 people. So it's real big.
Wow.
Yeah. It's probably. I would say, Eileen, that's probably the biggest health conference. Would you say? You're on mute. Sorry.
Yes, in New Zealand.
Yeah.
Yes.
So what is it aimed at? Like, is it aimed sort of data and digital, or is it more just health technology?
Both.
Probably both.
Right.
Yeah.
Is it? Okay.
Yeah, it's quite interesting. Yeah, because as we were saying early on, because it's like in conference overseas, you have this big theme and you have this big kind of like places where people are exhibition and so on. So probably the exhibition side is not so kind of you might see overseas if you have been overseas or you have this stalk through the website. But the whole theme side is just a lot of stuff going on there in this one. But yeah, it would be nice if it was more if you had the whole system, because I don't think everyone from the health system participates. I think it's mainly public, and some snips of the privates might be coming to participate just to see what's going on in the mothership.
But I think it's a good conference, at least for New Zealand. It's quite a broad, diverse, group of people coming together. It's health everything. It's not just technology. There's people talk about services. People talk about their problems. It's quite a good conference, I would say.
Okay.
Yeah, I'm looking at Wednesday morning. So the first session between 9 and 10:20, there are 36 talks.
Ooh.
Wow, that's
So is it like
amazing.
people jumping from talk to talk?
Yeah. So I think there's
quite a few different themes
running. 9 rooms running concurrently.
Definitely.
So there's which is amazing. So
does it always happen in December? Is that always like an end of year sort of?
It's usually November.
Yeah.
It's a bit later this year, isn't it?
Right.
Yeah, I assume that was to buy a little bit more time in terms of knowing what the COVID stuff was going to be this year, or maybe they couldn't book it early enough or something. I don't know.
It was supposed to be in Canterbury last year, and we couldn't make it.
Yeah, I think it's supposed to be in Wellington next year, because we've got the new conference centre opening in Wellington here, I think, in the middle of next year. So so that'll be cool. I think the last one we had was Hamilton, wasn't it?
Yeah, 2019.
Yeah, so it hasn't happened for 2 years. I think HiNZ has suffered for it in the sense that it's where they make most of their money as an association to keep going through the year, is through the sponsorship and things of the conference. So I think it's kind of crippled them not having the conference. So yeah, it's been a bit dire. But so I'm talking twice. So no, 3 times actually. So I'm going to the AI session on the Tuesday for the day. And I just got asked, someone's pulled out, can you talk in that? Like, oh, okay. Talk about whatever you want. You don't want me to talk about AI stuff? So let's talk about that. And then I've got a session specifically to talk about AI stuff on the Wednesday morning. And then on the Thursday morning, I'm talking about the
remote patient
monitoring stuff.
There's a lot of people talking about that across that work stream.
Yeah, I'm basically trying to figure out, have been for the last 12 months almost, what the key questions are we need to answer to do it systematically, because I think a lot of people are in the detail of, I want to solve this use case. I've got people with, heart failure. How do I solve that problem? And there's a team at Counties at Middlemore who've kind of come up with, I challenged them to come up with as many use cases as they could, and that number's over 50. So like either patient groups or places you'd use this type of thing. And that number's just insane. So you kind of go, well, we can't have 50 systems. That's just doesn't make any sense, and probably one doesn't make any sense either. But how do you get kind of the right balance in that context of?
So it just becomes kind of how you measure the cost of the opportunity, really. If you start measuring the cost of the opportunity, then you can narrow down quite easily what's the biggest opportunity you can take, the cohort and the cost as well, because it's not just the cost, it's the cohort as well. That how big is the cohort? Because it's only one or two, but lives far ahead, maybe lives whatever kilometers away, then you might justify that. It's really interesting. It's economic evaluation of that. That's
But I think there's a couple of interesting things in that. There's kind of the marginal cost and marginal benefit of add-in use cases. So, you have the best use case, or the best cost benefit use case as your anchor, and then you add in a bunch of more marginal cases as you go, because you've already paid for the platform, you've paid for the the model of care development or whatever. So it's kind of sunk cost stuff. So but 100%. And I think that's kind of there are lots of those things. So, and given how cheap some of the technology can be these days, we're comparing, we've got an example out of Nelson Marlborough where a district nurse was driving an hour each way to take someone's blood pressure.
Yeah, just that. You just take that, the cost of productivity that you gain for not doing that travel, or the risk that you put yourself through as well to drive into that type of region that's big.
100%. So just the petrol cost. So the technology would be cheaper than just the petrol, let alone the car maintenance, let alone the nurse's time. Do you know what I mean?
But now, if you take another lens on that perspective, and if you think that if the Health and Safety Act, it become really strong as it says it's going to be strong, literally you would try to minimize your risk of travel as much as you can with your nursing and your staff costs, because you don't really want anyone having a road accident and then become something major liability for parts. And I think the ambulance is quite interesting one as well, how you minimize that part. And then I was just thinking about the whole the blood tests from the Martin Tan, the little machine part, and I thought, imagine if you have that in an ambulance and they actually minimize the travel to the hospital, and then actually you reduce this whole 6 hours or 8 hours in the hospital already.
Why put it in an AD? Just put it in the ambulance, So
if you can stretch that to the next level, because then you have all this travel time, because ambulance is really so stretched. At least in Canterbury we have so many, but their responding time for patients, you actually call then. Someone was have a seizure in the streets another day, and my friends just stopped and tried to help, and the ambulance said, is this person okay? I said, he has some blood coming out from the mouth. but they said, sorry, but we don't have ambulance here to come to send you anyone to him. Luckily this person, he has seizure, apparently was the normal staff, just got up on the road and just walked back to home. It's like it was just really
that is the like when you're talking about so if you looked at the current state, like sort of the community teams that are going out and doing that sort of work and just focus on that, you miss the opportunity, I suppose, for some of that wider thinking around, how can we push that out just that wee bit more, and look at the whole system problem around some of that ED, triaging and access to care, and some of it is around just the reassurance, isn't it? I know we looked at some COPD devices that some of it was just around having a reassurance that you're okay, and then that was quite often enough just to keep them out of hospital, which is probably a worse place for them. It's sometimes for anxiety.
You thought you were sick when you came to hospital. Yeah.
That's right. Yeah. So it's having a look at that whole system as an approach around, I suppose, and delivering robustness so that we've got platforms to build on future technology as well. Which,
I think it'd be interesting to see it, after all those presentations, just to see where everyone's at in terms of productionizing all of those single devices. Because I think the challenge now is, the horse is bolted on some of those things. They're out in the system, which is not necessarily a bad thing, but it's kind of like, do you scale that up, or do you kind of pause it and reinvest in other areas? It can get quite complex quickly.
I think there's a really interesting question about how well integrated some of those tests are. And so most of them won't be integrated to the NHI. Most of them won't be integrated to, your existing systems that you use. And so
islands of information.
Yeah, 100%. So, and if you want the real benefit, it actually relies on you being able to either make the clinicians more efficient and effective, or actually intervene at the right time, which necessarily kind of speaks to that innovation work. So.
Yeah, and the other part is also, I think, that we need to bring back to the system thinking that Michael was talking about, is that even though if we spend the thinking of, for example, the Martin Tam device. Sorry, Sujan, do you know what we're talking about, Martin Tam device? So it's the blood test. Yeah, so it's the blood test that you can do now, and they have done a really small device that you can actually do that in ED instead of waiting for the labs to provide the results. It's actually, they can see straight, it's a point of care type of results, so which is pretty cool. And they managed to be so sensitive that they actually can detect whether the person is having a heart attack or not, and ruling out whether you need to go to hospital or not. So, but if you do have that in ambulance, you still need to kind of figure out the resource, because it's the next stage of the follow-up, where they go next to make sure that they are doing all the stuff. And that was kind of one of the challenges that Martin had, because really he reduced the admissions to Ward 12 quite. I mean, the reduction of admissions to Ward 12 is like, the graphs used to be like that in 2016. Now it's just literally like that. It's nothing. But then you create a flow into the outpatient clinics and back to the GP. So, and how to ensure that those two places are really well resources, and also well collaborating really well to understand that Martin has done such a great thing in ED, but someone else needs to clear the log.
Yeah.
Well, I think that, so the fascinating thing to me is that, we talk about general practice being all about appointments, and it's not, I mean, that's part of it, but a big part of general practice is actually all of the follow-up stuff.
Yeah.
And so, in that kind of context, there might be lots and lots of follow-up where, how could we take some of that effort away from a GP? Because if they don't get paid, the pitch to them, you're not getting paid for this, so just let us do it for you, and it'll free you up, free your evenings up, or free something up and reduce the stress for you. But in doing that, you need some sort of, fail safes, or you need some sort of alerting or something like that, which all comes back to what are your common platforms for storing the data? How do you make that available? How do you share it? How do you integrate it into systems that they want to use? And then how do you run algorithms on that? And then how do you notify people? So Robin Whitaker and I were having a really interesting conversation about, I think there's a core set of activities you do as a clinician, which are kind of reusable and repeatable. So, all clinicians write notes. So we know that. And either you dictate them into a letter, or you fill that into a form. So maybe we need some forms and some free text. And then generally you end up with a bunch of either jobs to do, or tasks to give other people, or orders to make, or referrals to do. And so maybe we need a tool that does that. But in order to capture some of that data, you kind of often end up capturing it from machines, or capturing that data from observations. And so maybe we need some way to do that. And then you go, okay, so that feels like a core of workflow tools for clinicians, And so you go, okay, well, let's start to figure out what we like, what would make a good one. So if you had to write notes, what would good look like in that context? And so rather than think about the applications, you kind of fill out the clinician's dream workflow, and then you start to measure some of the apps we've got against some of those things. Because it turns out, in having a conversation with some of the hospitals around the country, they're using the same application for different parts of the workflow, and not realizing that application actually does other things in the workflow. Because we bought it for doing this bit and not that bit over there, and we didn't even realize it did that thing. So we went and bought another app to do that thing, and you're like, so you're just making, in some ways you're kind of making work for yourself, because now those two things need to talk. And then it's different in another DHB, oh yeah, we bought exactly the same tool, but we do this thing over here with it, and you're doing.
I think what you need, John, when you go to the DHB, is you need to bring your Magimix. You need to be your bullet, your blender, and you need to bring your liquidification. So the three things, or do you stick blender? So because the three things does the blender stuff, but in a slightly different way. And one is for your carrots and some of the stuff. One is for your super vitamins, and the other is for your soup. So so you have the three things, and it's actually they do exactly the same, and they are giving the same sort of output. But this instance where you use those three things is slightly different. And I think that's what's happened probably most in our hospitals, that you have you need a blender, you need the stick blender, and then you need the bullet, the magic bullet or whatever.
Don't you just need a knife and a chopping board? Is that really what you need?
What we could do is unify to simplify.
I
think that would be a good approach. I think
you got the Vitamix then.
I think
that's a $3,000 one.
Yeah, I agree with you, John. I think like if we're going to make changes, we need to understand what the flow, because otherwise we just make changes to make changes' sake. Like if we understand the system from where to go and the actual, and then measure against that, what are we doing? Then we've got at least some basis for, measuring the change, and then did that work? But if we just keep throwing in, like say, different apps to plug a hole in the system, then and go, that fixed it, but actually, sort of like what you're talking about, Sully, about the Martin's devices, actually we just shift the problem to a different area. So now ward 25 is, or whichever ward is that we're outpatients is the problem. How do we fix that? We just keep jumping. Because it is complex, isn't it? Like, they always talk about it as a complex system that, that's my worry, I suppose, is that we don't know that enough. We don't capture the system flow.
So the other thing I would add to that is we're not really good at being able to describe how we do things at the moment, or use quite gross terms for describing what we do. Do you know what I mean? Like I said, every clinician writes notes. Do we even have a common standard of how we write notes? No. Everyone does it different. So, but I mean, if you can dial it back to that commonality and go, everyone does write notes. We might all write them differently, but let's just say we write notes, and what makes being able to write notes easier, and what makes it being able to write it harder. And so, I'm sure there's probably commonality in that, separate to what do you write? Do you know what I mean? So I think there's definitely stuff we can do which starts at the top level and kind of gets more detailed over time. So,
who's doing that work, John?
Well, so I said to Robin,
that's the other challenge, I think.
We probably need to start doing some background on this. She's setting up this clinical and consumer council for data and digital, and presumably this is the type of thing you take there, and then there's a conversation about if you endorse it, then it kind of feels like, as a system we've got I'll call it a standard, but it's not really a standard. It's kind of like a common set of principles around the design of things, and maybe that kind of moves us forward really, really well. Well, you're going to show us slides.
So I was just going to share that. So that's the stuff. I'm not just sharing with you. Can you see that? Can you see the screen?
Information you want?
So this was like, you see the date 2021, okay? So this is kind of like the stuff that we used to do typical and the Canterbury when we were looking for process flow. We just draw the process first, and we wouldn't really going through trying to figure out what's the question you try to answer. We literally would go in the process, draw the process, and actually populate those parts. And then how we use the data in Canterbury, we literally was follow the process flow, and then it started looking. And you can see that's coming from, in this case here, coming from ED to the specialty location, and then there's different IP wards, and we got these different stage times and capacity and so on. So this is stuff here was bread and butter for me in the past. I don't do that anymore, but that was bread and butter. But it kind of like, this is a kind of view that we don't have as a national view, and hardly you have that throughout the system here. But literally we could see where the problems were and how we could probably intervene on those different things. But, it's about the process at the end of the day. And if you don't manage those bottlenecks and the demand, you actually create issues. And that's the part that you can start clearly seeing why this is actually happening here. And then
so the interesting point I'd make on that picture is you've got relative numbers, so not necessarily absolute numbers, in the sense that you're saying it's recently 10 to 12% increase. I'm kind of like, but does that assume that the number is a good number? Do you know what I mean?
Yeah, no,
But-
that's just
Is it 10 to 12% on a good number, or 10 to 12% on what is a bad number?
Yeah, but that's the way how you look at information, though, because here when you start looking at the pattern here with statistical process control, you start seeing what's the good number and the bad number, and you can start looking that. But yeah, the first graph was literally to grab the attention of people to say, hey, you need to look into their stuff, and essentially you need to go into the detail. Yeah, that's right.
But I suppose my point is that there's two types of change. So the first change is 2,000 a good number, or should it be 1,000? And then your view is why has it gone from 2,000 to 2,400? You see what I mean?
Yeah. Well, what's the variability that's acceptable here? Because you just really technically, do you want variability or not? Do you want to minimize up or down or outliers?
Sure, but I can see a period, a week, where it was down at 1,200. So why is 1,200 not our number, our target?
I know.
You know what I mean?
Because the country was like, yeah.
Lock the door.
Brilliant.
Don't let anyone in.
Just close the door.
Scare everybody.
Just close the door.
That's where you get your numbers down. Close the ED.
Close the door.
Yeah. Problem solved.
Yeah, that's right. So you had a little bit here when we had the March 2019 as well. We had a little outlier here as well. So it's just kind of really, you could see the pattern over time. It's quite easily, but but that's the stuff is really what it was really.
Yeah, it's interesting that it sits around that 2,000 if you look across the mean, because then you can do rollout, say, for a population basis size in an urban area with surrounding, rural areas. If you look back 10 years, you could predict ED, volumes, or is that extrapolating too much?
No, if you look back 10 years, it's quite difficult because of the shift on the. So for us, in our case, in Canterbury, it's like different because of 2013, after the quake, we had all different changes in the population and how they shifted parts into ED. But in other places of New Zealand where you haven't had a major event, you would just see the increase per population would be more stable than compared to Canterbury. So it's special. That must say we are really special here.
So many reasons.
We're all special and different.
No. Here we are really special. So literally, it's just because we have those major catastrophic events. So our data became really skewed, and the ED, and then, but I think because of COVID, becomes more skewed across the whole country really as well. So it will make it really hard to actually. You need to get some when you start looking those populations. You might need to have a process. a break in 2000 until the COVID, and then actually just have this particular process and looking. But saying that, we have only 12,000 people extra in New Zealand as per stats. So, and that's actually is quite concerning, really, when you think that way.
Yeah.
They're all getting older, though, is what I'd say.
That's why.
It'd be interesting to see the recovery back to that norm before COVID, whether different regions did that at different paces or not, and why that would be. That would be an interesting question. Like, was it something that happened within that population group of the society of that particular town or city that made them less concerned about going to ED, and they found other alternative pathways as a result of not having the ED to lean on through COVID lockdown? I don't know.
We have seen. Sorry.
No, you go for it.
I was going to say that with an ED, and I just don't know how much the guys in the ministry are using the SNOMED codes, because the ED really gives a really quick feedback of what's going on in terms of needs in the population. But one of the things we saw is a really low staff in ED, like so the social staff, like people coming to ED with dental stuff, with headache, with migraine. If it's stuff that is actually, it's. The migraine is a little bit relatively different, but some other stuff that it could be preventable and so on. So it was really interesting to see that. But anyway.
So a more accurate measure would be the right people attending ED. So like, is there measures around how many people did attend and then were referred through to inpatients? Obviously that's a pretty coarse measure.
So there is a proxy, which is how many would GP referred versus just turned up, and so you can do that by triage category. So you can look at triage 1 and 2 you probably didn't want to go to the GP in order to come to the emergency department. So you kind of treat them as being legitimate. But then for triage 3, 4, and 5, you say, if you've gone to the GP and now you're an ED, you're probably legitimately there. If you're 3, 4, and 5 and you've not been to the GP, then there's questions about whether you should be there. So like there's proxies for that. The observation I make about the SNOMED things. So SNOMED is good at codifying stuff, but we run into the same problem we have where if the person codes the wrong thing, all we've done is code the wrong thing really well.
I know.
So I had a look at Christchurch EDs because I was looking for Martin Dans for his IKEA Faster thing, figure out how many people turn up at the emergency department with chest pain.
Oh no, but it's very variable because you have you have chest pain, you have some different things.
It's all highly accurately coded, so there's no spelling mistakes anymore. So chest pain is spelt right every single time. But there are a bunch of people that come in for an ECG, and you're like, well, why did you come in for an ECG? Do you know what I mean?
Yeah.
So it's not the ECG you came in for. Do you know what I mean? It's what happened when you were there. So.
Is there a subset of population too that didn't come into ED that were really sick, and so that's a bit that we don't measure that then come in later and they're obviously needed. I mean,
more intensive
we only
treatment.
That's right. Yeah. So we only know what we know. Yeah.
Yeah. Now you can see the ones that are actually coming through because again, you can see the ones that are actually coming through the 3 times, and actually the 3rd time they come admit into the outcome of their inpatient admission is cancer. So then you actually see that something happens through the process that was really miss, or it's cancer, or is actually they come with back pain, and then end up having a surgical procedure because they have been taking so much painkillers for something, and then end up having a gastro stuff going on there, and the actual original problem they had hasn't really actually been dealt with. But and then you just start creating those. But again, it's the numbers are so small that's really hard to say how big is the problem. You know that's happening, but you don't.
Well, I think it's heterogeneity in the sense that you with 2,000 people a week, 2,500 people a week come to ED, and I think that there's chest pain is probably one of the most, or possibly is the most common reason people come to ED, and the other one, abdominal pain.
Yeah, but that's the two.
That's a symptom, not a diagnosis, and not a treatment. Do you know what I mean? And so you end up with like this many, like a list that's this long, and you end up with like 2 people had this, 3 people had that out of the 2,500. You're like, well, putting a system in place to manage that's really hard.
Yeah, with the COPD it was quite interesting because we used to have 40 or 50 attendants a week in ED for COPD. I think it was a week, and they managed to reduce that 24 or something like that before the COVID. And within that, you managed to reduce for 7 days of those 24 that didn't really become a inpatient. 7 days of bad days was reduced with that process. So it's kind of like sometimes a cohort of 40 a week, you can do a really good change, and that's what we notice in Canterbury. For 40 weeks, you can make a really good change, a good impact in terms of ward admission and so on, but you just need to find those 40.
You have to find that common factor, eh?
Yeah.
Wouldn't it be great if we got to a preemptive on that? I know we looked at some of that as well, is that using some data, environmental stuff, so that's for COPD, hang on a second, we might get a peak through here, or how can we minimize their attendance by other measures, by saying stay indoors, shut the windows of the
pollen.
That's right.
Michael Louis got some researchers doing some stuff on that in UC around asthma and around COPD. So they're building a new hardware device which measures isn't like a peak flow monitor, is actually like gives you full inspiration, expiration, elasticity of kind of the lungs.
I went to that presentation.
Quite interesting. Yeah,
we need to measure, and that comes back to that whole, what are we, that data that we don't know at the moment at home could be useful for, so it's understanding, the stuff that we know, that we want to know, but it's the data, the other data that is, we quite often discard.
We find it out at the end. Do you know what I mean?
Yeah, that's
So
right.
you're in hospital and we decide to do some lung function tests on you, and it turns out, rather than you could have done it before you went to hospital.
Yeah.
But it's a little bit like Interi. So I was doing some work kind of in the early 2010s around predictors of hospital admission. So medicines obviously was a good predictor, previous hospital admission was a good predictor, and turned out Interi assessments were a good predictor, not because they were done before you went to hospital, but basically everyone that was old that went to hospital got an Interi done. And so you're kind of like, maybe we should be doing Interis before people go to hospital rather than once they're in hospital, in that kind of sense of, if we did Interis routinely for older people, maybe we'd find some of these problems before they ended up in hospital. So yeah,
was that the genesis of the community-based Interi assessments?
No, so we were doing them, but we were literally doing them as a result of old people ending up in hospital, not as a way to understand before they ended up in hospital how we keep them out. Even that was an ambulance at the bottom of the cliff.
Yeah, I guess reflex. The whole balancing strength of the program that we have nationally with ACC is pretty good. I mean, that helps to probably flatten the north and so on. But still, you have other things that you need to consider when you are. I mean, anyone every 85 and so on. You just kind of like, you really want to have a watch over. I mean, some of my neighbors would be horrified if I say that, but I say I'm independent.
Yeah.
And then David,
put a camera in their house and monitor them 24 hours a day, 7 days a week. You know, happens in some countries.
Yeah. Maybe just infrared ones on the outside.
We thought about doing that. So my mum, diabetic, lives by herself, and we already have the wireless glucose monitoring and that sort of thing. What it does is like just creates a little bit of anxiety, or like it has, like even me, like I haven't got diabetes, but I've got blood sugar anxiety. Looking at it.
And food.
That's right, yeah.
Like too much knowledge. I don't want it.
I mean, this is, I suppose, the other side of that, is all around that data. How do we use too much data? Like, what do we do with it? Like, we need clever systems to encode, like the AI around decision making early, or highlighting data that's important.
But sometimes it's people, how do you actually effective help people to change behavior? And that's really no matter how data we have, because diabetes, high blood pressure, and some other stuff. I mean, it's quite mean when you don't know, you think that you're healthy and fit, and you have some other underlying conditions that are really pretty tough. But some other stuff, when you're actually, what you're doing is not good for you, but you carry on doing, how you help those people to change behavior and pattern. That's a really tricky part.
So interestingly, Ruth Kibble's just finished her study in South Canterbury around wearing the bio button stuff, and I kind of don't want to steal their thunder too much, but one of the things that is really interesting coming out of that appears to be putting a button on someone that the health system then monitors has resulted in those people becoming quite motivated to want to continue to monitor their health and do something about their health. And it's interesting because you might think it was creepy until you had it happen, but apparently it's kind of turned them around in terms of, I can see the information and I can see I'm normal or I'm not normal, or I'm glad someone's looking at this. It feels like I'm being cared for rather than it being creepy. And that's funny because it goes along with a proof of concept I did last year with data mine on giving all of the border workers in Auckland Fitbits if they wanted one. And so it was really hard to actually get people on the trial. Here's a free Fitbit. Would you like one? No, thanks. But when you gave it to someone, like the feedback we had was really good feedback. So the people that took one and wore it didn't want to give it up afterwards. So that's kind of interesting. It's that people fear what they don't know, and maybe having some of these things is actually, once you get it, better than we might expect the experience being.
I totally agree with you, John. And I think from personal experience myself, I haven't really worn my watch because once the battery died, and I somewhere lost my watch. But I was able to keep on track of my, it kind of like become like awareness that how many steps I have done a day, and how many, when I work from home, I'm really bad. So I can't literally, I need to motivate myself to go sit on the bike or do something that I can move. Otherwise my, you know, it's just really, really hard to get myself do the steps that I need, and end up you injure yourself.
You and me both. I had to go for a walk with the dog last night because I worked from home yesterday. So I looked at my watch yesterday, and then I was like, "Nah, got to go out." I ended up going for a big walk with the dog, which was good. So
it depends what motivates you. I suppose that's what, you know, comes back to that personal thing, isn't it? Like understanding the individual, and then, you know, what is the motivator for change? You know, some people just won't be open to that at all. They'll think, man, I haven't done any steps today. This is stressing me out. Or
Well, so interestingly, it's like, and once again, I don't have the detail on this, so we'll have to wait till Ruth comes out with it. But it appears that a large number of the people that they were obviously putting on this trial were people that hadn't managed hadn't been able to manage their health well, and so were likely to end up in hospital and blah blah blah. And some sort of combination of being able to see the numbers yourself, knowing that someone's looking at the numbers, and if things go wrong, you'll get help. And it being a bit normal and a bit different and better than having to go to the hospital. Apparently, so that's kind of been quite a motivator for a group of people you might have thought historically weren't very motivated to look after themselves. So it's an interesting thing because, like I said before, it might be more effective than we think it is.
It's interesting because you could apply that particular research that she's doing to the green prescription side, because the green prescription has been, the problem is that you can offer, but if they're not ready to make the change, they will not really, you know, even if it's free. And that has been the same with when I spoke to the respiratory sleep clinic. What's his name? Michael.
Paul Kelly Tudor.
Paul Kelly, that's right, Paul Kelly. And I said to him, if he had an app that he could actually evaluate his patients to actually say which ones are actually ready to be in a CPAP machine, probably would be a better use of their time in evaluating those patients quite easily, rather than actually giving the CPAP and then later evaluating whether they're using or not the machine. And that's a conversation I had with him about 3 years ago. I'm not quite sure whether he took on board my my wise knowledge, because I felt that it was a similar correlation with the green prescription. You know, you can give stuff for people, but if you don't really take ownership of that, you need to
in a box in the corner or whatever.
Correct. And it's
but the interesting question I've then got, Soleil, is, does he ever look at whether people use the machines, or does he ever, do you know what I mean, give them feedback about not wearing it or wearing it or whatever? You know, are you wearing it right, or how many days in the last week have you worn it? Or
that's a really interesting one, because again, it's a health and safety issue, and they if they are not monitoring that, I think I think it's something about with the company, the employee as well, that refers the person to be able to ensure they have a really good quality assessment, especially the truck drivers and so on. And he does monitor the user of those machines, because they have all kind of like the radio frequency stuff used as well, so they know where they are, and they actually using that. They change the parts, so they are doing that. But yeah, again, it's going back to the question first: are they really motivated to use the machine at the first place, rather than waste your time installing and setting up
and then realizing they aren't?
That's
totally. But then it's also one of those things that you're going to lie about as well as a patient, you know, like, so you go to your GP and they go, do you drink too much? And you're like, oh no, definitely not. And have you started smoking again? No, I don't smoke. Do you know what I mean? It's and how much are you exercising? Oh, more than enough. I exercise all the time, every day. More steps, the better. You know, and so, you know, kind of telling people what they want to hear. So there's kind of this. We know that people are more honest with computers than they are with humans, which is quite a funny thing. So maybe we should be getting the computers to do more work for us, because people won't lie to them, I suppose.
Yeah, I suppose that's like, you know, putting people in a vulnerable position, aren't they? And doctors, they feel, you know, if they admit to that they're that's just opening them up to that, you know, honesty, and I suppose that's where computers probably a bit more forgiving from that point of view. But
wiser type thing,
What
if I write? What if I write 10 beers a week instead of 5 beers a week? Is that real bad?
Well, I suppose if you had that real-time feedback, like, you know, what effect would that have on me? So you could type in like, oh, I'm going to have 10 beers this week, and then oh man, that my blood pressure's gone up by, so if you had a real time sort of app around, I'm going to have 6 pieces of chocolate cake. And 10 beers. Like, what does that look like?
And a couple of durries. It's like, but that's kind of you can say it to a computer and take it back again, and no one's the wiser. Whereas if you say 10 beers to the doctor, and then you get the like this look from them, you're like, oh no, it's 5. But you've already told them 10. Do you know what I mean? So you're kind of like always a bit suspicious about no take backs. So.
And do the doctors already know that, so they tailor their data based on like he said 5, that's right, but actually look at him, like he's had 10 beers.
But it's a little bit like the mental health, the add-on part that they say always the first one is very hard to get a true measurement, whether the use of depression, alcohol, and drugs as well. But then it takes some time for them actually to part. But because it's only, I think, 6 months, they're saying the service, some of them is actually not sufficient to actually say what's the change that happens over time. So I think that's. Yeah, I think those evaluations are pretty, it's good, but if you could follow that over time, but you cannot really hold someone in the service just because you want to evaluate them to see over time. So
something that I had an idea the other week about some of those digital mental health services was, maybe we should be trading access to something like the NHI number with, make sure that, you need a measure. So if we're going to give you access to the NHI, you need to measure one of these outcome measures with your consumers, as a baseline, and then every month or whatever that the person's on there. And then we're gonna, we get the data for that, and we're gonna publish, outcomes as a consequence of, all of the people that are using these apps. So we can start to measure kind of which are the better apps for different types of people. So we've captured NHI because we've given access to it, and then we've got outcome measures. We can start to see, this app's really good with young people, or this app's really good with Māori people, or whatever it happens to be. This app's better for depression. This one's better for anxiety. You start to apply some actual kind of comparative analysis to some of it, because it's quite divorced from that at the moment. Do you know what I mean? There's lots of subjectivity in some of that.
Yeah, but also that if you look at the ones that are actually the most acute, that actually accessing the NGO service, like the Wild Bamboo Group, they actually have really good tools in place to allow that type of monitoring that, and which they could give a really good sample what's going on in the population that they're dealing with, because they're quite part that, and some other providers I think have that type of thing, and already probably sharing their information with the patients and actually delivering the plans together. So that I think that part, but I think overall the general population, the ones like myself, yourself, and everyone else that is not accessing a mental health service, and sometimes you are a little bit low, and how do you measure that part that you're not tipping to the edge, that you actually need support, and those apps, of those free apps might be giving that sort of generic advice, the wider population.
But I think in some ways, at the moment, if you needed to use an app, there's no real way to know which one would be better for you. Like, no way at all. You'd have to download them all and have a go at them all. And so I kind of feel like you're right. There's a bunch of stuff that you're probably not going to measure by doing this. But in some ways, if you're an app that thinks it's really good, presumably you definitely want the data published. Do you know what I mean? Like, because, we're going to look really good in this versus, and it might push a number of them to try and make things better. Hey, yeah, we want to make our numbers better. So we're going to focus on making our numbers better, which presumably is the right thing to do, I guess. I don't know.
Yeah, I think mental health is a bit, I think that you need a diversity of the products for mental health, because it's so very...
Oh, yeah. No, I'm not saying you wouldn't, but all I'm saying is at the moment it's almost like it's a black box as to whether these things actually work. I mean, so there's evidence that online CBT does work, but presumably it's more or less effective in a user interface and customer experience context.
Yeah, and what type of person is more effective as on someone that actually is good to follow rules and very prescribed in its structure, or someone that's very random, never had the rules in place, and it's just like someone would be really good.
Take it and leave it type stuff.
And that's I know that some people have really been very successful using those tools, but also I know they have been highly structured themselves as individual, and probably if I use this tool with me, it would not work, because probably it would just be sign up one day and I say, yeah, that's cool, and then I would just kind of like.
What every day? No.
I suppose that's a good point. Like around, if we're getting to a great place where medicine's more individualized and it is considering the individual, are we better to have lots of apps that people can make that decision about what works for them, but in the background the data links together, so we're all talking about sort of we're closing the loop on this around those measures, like what's and again the same for like what is the measure for happiness for individuals is different, isn't it? Like we're never going to get to an agreement on that, what makes one person happy compared to another. That what is the social factors that you look at around?
I think it's totally the case that one person's measure of happiness is never going to be another person's. 100% agree. But totally the technology kind of side of this is very much separating experience from the data from the platform. And this is where integration and ecosystems and APIs become kind of the key thing. How do you go to Europe on holiday, bring your phone with you, and can open Google Maps and find the nearest petrol station and figure out that it's the cheapest one, and then go and find the hotel that you need to go and stay in, or your parents' house, or whatever it happens to be. That's all, and that's all free through Google Maps. Google Maps makes money through other things, but at the point of use, there's a whole lot of services that are fully integrated, and how has that happened? It's kind of a really interesting question for us.
Yeah, we need Google Health.
Well, so interestingly, there was an announcement yesterday, I think, that Google's licensed one of its algorithms to a PACS and RIS PACS supplier, because the AI they built, they basically can't. They have no route to market to sell it. So they don't sell PACS systems or RIS systems, and so rather than try and sell it, they've licensed it to the PACS and RIS supplier in the US. Which is an interesting kind of admission from Google that maybe they shouldn't be trying to do everything in a healthcare context, and they actually need to partner with others. It's quite a change for them, I think.
What was the company in Auckland has been doing the ring that can measure the pressure and measure the stuff, and I think there was something about using some of this platform as well to be able to.
So there's Aura Ring, OURA, but I don't think it's I'm not sure it's an Auckland product.
No, I'm not quite sure if that's the one, but there's one group in Auckland are doing the ring thing, and they are actually it's in the MBI website that talks about their product and the company, well their successful story is. That it's quite interesting. You have those random companies doing these amazing things, but it's
that's amazing. I started. That was my health journey actually. 21 years ago, was building a ring that could measure pulse oximetry. And you can imagine 21 years ago, technology was massive. It
would have been a big ring. It would have been a really big ring, Michael.
Well, we actually got it down to really small with a watch and an attaching cable. But yeah, it's amazing how far, like looking from 21 years ago to what you can pack in there now. With even like we had to make our own communication language because Bluetooth wasn't really a thing and Zigbee was just starting, and we had to make up everything from scratch. That it amazes me that idea from 21 years ago is sort of refreshed again into this is perfect for sleep studies and that sort of thing, where you don't want to be attached to all sorts of things.
So someone was talking to me about whether or not you could predict someone's sleep apnea risk with metrics that mean that you didn't actually need to see a sleep study. So sleep studies are a kind of a product of a bunch of things you might be able to measure on a person when they're awake. So someone out of Diana Sue's area, TTM, is doing some work in that space, I think. So there's a project looking at it at the moment. Pre-screen, basically. So, step back from the CPAP, step back from the sleep study, back to the start, which is who should be referred. Do you know what I mean? Like, have you got sleep apnea? Have you got high risk for sleep apnea? Yes, no. Well, if yes, then we're going to do a sleep study rather than have to see everybody, do a sleep study, and then figure out whether we're going to do anything. So.
Yeah, I always thought because they use SpO2 quite a bit for that. But there's such a lag in that, if you hold your breath and pass out, it'll still be reading 95% for a long time. Like CO2, like you go back to, the technology they use in hospital for babies. And, even just chest movement, I know they use that sort of thing. But, just wondering whether we're applying the wrong technology to make some of these decision-making things on.
There's a really interesting question for me around, the sound of your voice. So we were talking to a big drug company a wee while ago about maybe about a month and a half ago. So they're running a study in the US, which is using the sound of the person's voice to identify a respiratory infection. And so I was like, oh, well, it's so hard. You probably do that with heart failure. So, if you get your heart failure gets too bad, you get water and fluid in your lungs, and obviously that changes the sound of your voice as well. So I think there's probably a bunch of variables you could look at, which are both quick to change, it's slow to change, but are natural measures, if you know what I mean. So how many steps you took yesterday, coupled with how much do you weigh today, coupled with what's your voice doing, plus your blood pressure. Add all of those things together, and suddenly you've got a useful kind of metric rather than one of them, and hoping that it's either responsive enough or is not being compensated for through your physiology. And that's one of the interesting things is your body will compensate a lot for poor physiology. So it takes a while to kind of knock it to 6, or you have to put things quite out of kilter, to your point about CO2 or going unconscious, in order for it to be measurable. Your body's just compensating the whole time. So
that's right.
That's just interesting. Hey guys, I might just need to go. It's nearly 4 o'clock anyway.
Yeah.
Thank you so much. Looking forward to you guys. And Michael, I'm sorry that you'll not be there, but
yeah, I'm having a look at the program now. So yeah, I'm crying that I'm not there. Maybe next year.
Yeah, you're gonna have to come next year now. Now that you know about it.
We're more punctual next year, probably the whole theme, and it would be nice if it was a really, really cool focus of it, really, where you could get people together to solve those problems. That's the opportunity you have, like talking about sleep apnea here. If you have a rackathon there in that particular environment, that you could do that, thinking about how can we solve the stuff here. So it would be a really cool thing to do within the HiNZ.
Well, that's kind of an interesting thing, Soleil, in terms of maybe we should have a design lab at
Well, I was going to say you should book some time, John, to hold a session.
Yeah, or it's just like really to say, how can we, if we're going to make HiNZ the best use of everyone's time and not just a networking feast, but actually everyone goes with an agenda that actually can help solve problems. That would be really cool, because that's what's I stopped going to HiNZ because I just didn't feel that I could actually, just going there to chat with people without really having a clear agenda. What can I bring back to Canterbury? For me, was not very good use of my time. And I was thinking, if I go there, what's my agenda to bring back to the organization? So because it's actually they are paying for me to, we're presenting this time, but other times it will be someone's paying for me to be there, and just to go to with not really part. I think that would be really cool to have a Mike, you mentioned that.
Session.
Yeah, it's a dedicated session, and just talking about this technology hasn't changed for X amount of years. Is that a room for change here, or is that the only thing that we can do?
Because I imagine you have clinical people there attending, so you get that whole breadth of the system, which is great around getting some of that idea around understanding the system problem, the technology, and then the information, and putting that all together into a stream of solving. I know they sort of tried that for something. They wanted to make a Star Trek sort of, what's that thing on Star Trek where you wave over?
Tricorder.
Yeah, tricorder. I don't know where they got to with that around
I think
solving that.
They did have a prototype that did some measurements.
Right.
But yeah.
Maybe it's
bring your soldering iron, Michael.
Maybe the question, John, is actually what's the biggest opportunity we're missing that we're not asking the right question, or what's the technology that hasn't changed in the last 20 years and we think probably could be some change, or just coming with some big bold questions and really like curious question, really, because if we don't ask, we don't know.
Yeah, I'd almost put it the opposite way. What's a thing that we could do really quickly, really dirty, and really easy? Do you know what I mean? Like, because why aren't we doing more of them? Do you know what I mean? Like, that's an interesting question.
Yeah, telehealth, like that one around, what are we measuring at home? Like, just get all of the ideas and then some, just understanding that side of things around, measures.
Mirror board.
A real one though, with post-it notes, real post-it notes.
Real post-it notes. Ones you can rip up and fall off the paper, off the board.
That's right.
And the other thing is about that population we're not capturing, because I think the ones that you're capturing, for example, within St. John's, they already got the little caller, the alarm, the half of the elderly have that. And probably what we're not doing is collaborate more with St. John's to pick up the codes that we're not seeing. And they are just false alarm. They just check it in, and that's where probably they're doing the job to try to refer to someone else to look after the person. But yeah, it's kind of like the eyes and ears of the systems that we're probably not seeing it.
Well, it's the signal that is over the last 6 months. She's gone from never pushing her alarm to pushing her alarm 4 times a day. Yeah. And it's not that she needs to go to hospitals per se. So St. John rings her up, and but you kind of go, you weren't pushing the button 6 months ago. How come you're pushing that 4 times a day?
Correct.
That's kind of the signal that you want to look for in some of that stuff.
Yeah, and St. John being so busy as they are, probably they're not looking to that way because they're probably in the way of trying to kill the noise.
Oh, great! You don't need to go to hospital. We'll take the ambulance somewhere else where it's actually needed. So
Even understanding, like, the vulnerable population, like, so that person then lives by themselves and the button's the only means of, like, so that's a higher priority, like understanding, the button pushes in the whole system, like which ones are at the top, and who can get them. And that's where, like, pulling on community, like, rather than going to somebody, like we used to go down to the old lady down the road, they'd ring us instead of St. John's coming out. And sometimes it was just going down there and saying, hey, we're here, it's okay, and that was enough. The other times it was obviously more serious, but I think we need to pull more spider web connections into and chance of making communities stronger, linking, like after the earthquakes. That was a really good example of how people came together and supported each other. Maybe that's why the numbers dropped off.
It's the whole system we're working to make sure that it's not you wouldn't come to ED if you don't need to, and you were coming with you, and where the help was available as well, because you had different points to seek help. But it's interesting how the system responds. I mean, when you need to act together to respond.
Oh well, it's been a good chat, and we'll chat again in a couple of weeks.
Yeah, see you next week, Aileen and John.
Yeah, we'll see you next week. Yeah.
See you, Michael.
We maybe we can design something next week, Soleil, rather than just talk.
Oh, we can do the book of Aileen and the Minister of Health saying that you said, Stefatora, you said that people come to talk to us. Perhaps we should have a little card there here. But it's good to have something.
But if you want me to solder something up afterwards, make sure you do a good sketch so I can.
A good circuit diagram. We'll do.
Yeah. Anyway, see you guys. Bye.
See you later.
We'll see you later.
Bye. See ya.
Bye.